for the fourth and the class for this edition of online teaching program for postgraduates in pathology. Today we are here for a first session, that is slide seminar themed session, which is a very beautiful topic. Why should you be a pathologist? This will be taken by none other than the best pathologist of our country, Dr. Anita Borges, ma'am. She is the lab director and pathologist of Center of Oncopathology. Though ma'am doesn't need any introduction, we will be having 7 interesting students who will be here for the discussion on the same topic. Dr. Dharanshri from Pondicherry, Subhashmita Bhubaneswar, Abhinash Sahu from Behrampur, Ajay from BJMC Pune, then Aarti from Tirunelveli, Manasiya from Srinagar, and from welcome you all. There will be on the next Thursday, we will be having a second session, like what is language, the basic terminologies used in pathology, why and how to describe. This will be dealt by Dr. Siddharth Datta sir along with Dr. Anita Borges ma'am.
Yeah, I think Siddharth will be doing it and I will just be the chairperson. It's okay.
Yes. Okay. The moderators for today's session is myself, Dr. Sakshi from Guwahati, and my colleague, Dr. Bonita Bora. She is also from Guwahati. There are a few reminders on connection interruptions. I would request if you can rejoin, if you can leave and rejoin with the same link if there are any interruptions. Though I don't think there are any poll questions today. There are a few disclaimers. These are a few more disclaimers. Again, I think I should hand over the presentation to Anita ma'am. Thank you, everyone. Let's start.
Thank you, Sakshi. I'll just share my screen. I hope it. Okay. All right. We had a very interesting conversation. Some of you were privy to that conversation, and it's about. Let me do this. Yeah. About why actually are we asking this question? Why pathology? Okay, and I think all of you who are here, I don't know if there are any clinicians. I doubt there are any clinicians, and I doubt very much there are any undergraduate students over here. This question is probably more relevant to them, those who have not yet taken pathology, or to understand from clinicians why they became clinicians and they're not pathologists. I think it's an extremely good question to ask. Why pathology? But for us, those who have taken pathology, it's a little bit late in the day. Very few people I have heard of in this country, do a postgraduate degree in one branch and then go to a completely different branch later. You usually continue if you've done medicine, then you might do a DM in some subject, or you've done surgery, you might do an MCH, but it's more or less in one stream. So nobody changes. So once you have chosen to do pathology, and I take it that almost all of you have chosen to do pathology, or let me put it the other way about, whether you chose it or it was chosen for you, you are all in pathology. And we had both the moderators over here, we were just chatting before, and one of the moderators didn't want to do pathology, actually wanted to do pediatrics, but ended up doing pathology and actually does not regret it. On the other hand, absolutely enjoys it. The other moderator took pathology by her own choice and volition, but is wondering now whether she made the right choice. So there must be lots of such stories. But I would like to approach this from the point of view of, all right, let me start and then I'll tell you what point of view that I am approaching this from. Okay, 1 second. All right. First, I want to ask, we have 6 or 7, I don't know, Ruchi, how many do we have? 6 students here? Or the rest of them can please type the answers in the chat box. And we have Bonita and we also have Sakshi. And you can just generally tell me what the answers are like, okay? So what is the first question? And that's the question we were discussing. Did you opt for pathology by choice? So let me ask Mansi, did you opt for pathology by choice, Mansi?
Ma'am, it was not the first choice, but definitely.
It was not your first choice. Okay,
Yes.
so it was not your first choice. Very good. Jyoti? Jyoti, you there?
Yes, ma'am. It was my second choice, ma'am. Post
Again,
radiology.
it was your second choice. All right. Avinash?
Yes, ma'am. I opt pathology by my choice.
Oh, it was your choice. Very good, Avinash. Dharani?
Ma'am, it was by my choice, ma'am. My
Oh,
own
very
choice.
good. Ajay?
It was my second choice, ma'am.
Second choice. Okay. Aarti?
Actually, I love pathology, but my family want me to join in OG. I joined in OG in the first counseling, and right after 2 weeks, and I thought my decision is not right. I love pathology, so in second counseling took
Oh,
pathology
okay.
and
So
joined.
you are a kind of a convert, not really. I mean, you converted from your family's religion to your own religion. That's very good, Aarti. Excellent.
Thank you.
And there is this, I didn't meet her on the in the trial, nor did I meet her now. There is her, I think it is Subhash Mitta, or is it a man? Is that
joined,
sorry?
no, not yet joined.
Not joined. Okay, so that's fine. And what does it say in the chat box? So it's even over here. 3 wanted to do it by choice and 3 did not. What's it like in the chat box? Sakshi? Hey, can anybody see the chat box?
Yeah, Anita.
Yeah,
Neeru
similar
says
is there in the chat box.
All right. So there are by choice. Some people are saying not by choice. So I don't know. I think
Yes,
there
ma'am.
seems to be a
Some say second choice, some say almost now the poll has rose like almost 50% now we have by choice and 50% not first preference, but
so
it was there in the
yeah,
second
it's
preference.
okay. I mean, so there seems to be a kind of a mixture of
there may be a bias. There may be a bias here.
there
Who
may be a
have come to
bias. I
attend the
mean, this
talk.
is not something that there's when I last looked at it, there were about 60 or so people. I don't know if the number of participants have increased, but whatever it is, all right. And now I will ask those who did not take it by the first choice. Okay, if you did not, do you remain disappointed? Okay, I told you we had 2 moderators, and one took it by choice and then got disappointed. One did not take it by choice and became a convert, became literally in love with pathology. So Mansi, you didn't, this was not your first choice. So now can you tell me, do you remain disappointed? What was your first choice, Mansi?
Ma'am, radiology was my first choice, but
Radiology.
yes, ma'am,
Are
I
you
was not getting
disappointed?
it. No, ma'am, no, ma'am. I'm in love with
You're
the
not.
staff.
Very good. Okay. What is it that that now satisfies you? You're second year student, right?
Yeah, ma'am, that exploring the diagnosis and that like we are working in the background and then giving the clinician wait for our reports. That is
I
something.
see. Okay. So you've realized that clinicians wait for your reports. Excellent. Jyoti, you're there,
I was
Jyoti?
interested. Yes, ma'am. I was interested in diagnostic, whether it's radiology or pathology. I was prepared for both, ma'am. I was okay with both. So it's very satisfying now.
Oh, all right. But you were interested in diagnostics. You were not,
Yes, ma'am.
neither of
Radiology.
you were, okay. Neither of you were interested in the clinical branches. Can I
No,
ask you,
ma'am,
you
I
were
don't.
not interested in the clinical branches because you felt that you were women and therefore it would be very heavy and you wouldn't be able
No,
to
ma'am, not
manage
much
your.
like that.
Then tell me,
No, ma'am.
or you felt that it would be easier to get into a diagnostic branch and there's too much competition
No,
in the clinical branches? What?
no,
You
ma'am,
can
nothing
answer,
like
Jyoti.
that.
Hmm.
Yes, ma'am. Ma'am, nothing like that. I don't know, from initial years also, I was very interested in diagnostic because everything is gray zone in medicine.
Okay. So it's a gray zone and you felt that diagnosis
Yes,
clarifies the
ma'am.
gray zone. Okay, very
Yes,
good.
ma'am.
Mansi, what about you?
Yes.
I'll come to Ajay in a minute. Yes, Mansi? Why did you opt for the diagnostic branch?
Ma'am, initially, like when we are preparing, we don't have much like career counseling or somebody teaching us or somebody letting us know. Whatever from my perspective and from my friend's perspective, from my parents' perspective, like I thought radiology and pathology, these branches would be good for me. Like,
I see. Okay. And Ajay, what about you? What did you
Yes,
want to
ma'am.
do,
So,
Ajay?
my first choice was actually psychiatry, and
Psychiatry. How
yes.
nice. All right.
So the thing was key when I was in my doing my internship, the thing
Hmm.
that I noticed a lot, like especially in these clinical postings, is
Hmm.
that especially in government institutes, there is the amount of rush and patient load that is there, and the amount of understaffing. It always felt like a kind of disservice to both the patient and to yourself, like the amount of limited amount of time that you get to spend with each patient. And I kind of had this thing in my mind that if I am going to deal with a patient in a clinical sense, I would rather it be like something like psychiatry, where I can actually sit down with the patient and actually give them the time they deserve. Or if that was not an option, I would like the reason I chose pathology was because you do actually give, like, it's not like you scanning every single cell, but you still feel like you are doing your level best when you're looking at something.
So for you, pathology was about what? Is it about, like clinical pathology or something of that sort?
Yes, ma'am. But
Okay, so that's what you knew about pathology. All right. So now the people in the chat box can also write this, about this third question. If one had a choice between the following, which would you choose? Now each of you can say, Mansi, between pathology and dermatology. Because both of them are sedentary branches. You don't have to rush around. You don't have to do things. What would you have chosen, Mansi? Mansi's disappeared. Jyoti? Yeah, Jyoti?
Yes, ma'am. Pathology, ma'am.
You would have done pathology. Okay. This Avinash?
Yes, ma'am. Pathology.
You would have done pathology. Okay, good. Dharani?
Pathology only, ma'am, because all the skin lesions look same for me.
Because skin conditions look the same.
Yeah.
Asha. That's interesting, I must say. Ajay?
yeah, pathology.
Pathology. All right. Okay. What about oh yes, we have Aarti over there. Aarti, what would you have done?
Pathology for sure.
Pathology for sure. Okay. What about pathology and radiology? That the two of them have already answered that they would have preferred to do radiology rather than pathology. And anyway, Avinash, you decided that pathology was your choice.
Yes, 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 ma'am.
Yes, very good. Ajay, would you have even considered radiology?
I think was like at one point it was kind of at the same level for me.
Ah, okay. And there are people in the chat box I see, quite a number of them are saying that they would be happy to do radiology rather than pathology. Now, what about pathology and microbiology? Because many of the things that are plus points for pathology also apply to microbiology. So let me ask those who wanted to do pathology. Avinash, suppose
Yes,
you
ma'am.
didn't get pathology, would you have been happy to do microbiology?
Yes, ma'am. It's also a diagnostic department.
So you're happy to do a diagnostic branch. Ajay,
I did not have as much of affinity to the subject, so I would still
Okay,
go for
Aarti?
pathology.
No, ma'am. Maybe I'll write the next NEET.
Sorry, what did you say?
Ma'am, if I don't get that, means I'll try in the next NEET exam, like that I was telling.
Oh, you would have tried in the next, so you don't think that microbiology was a good choice. Okay. Now, how many of you would prefer pathology to physiology? All of you? Did you even consider physiology, Mansi or Jyoti or Dharani? Any of you? No. Can you just quickly tell me why, Aarti? You don't think that physiology is a good branch?
And like that, ma'am.
What's
No
the
idea,
difference?
ma'am.
You have no idea. Ah, that is interesting. So you had no idea about what physiology was all about. Ajay, did you know what physiology was about?
Kind of, ma'am, but like I still wanted some level of clinical contact, and
Clinical
physiology always
contact.
felt like completely academic to me. I do love the subject,
Academic.
but
Okay.
yeah.
All right. Dharani?
Ma'am, for me, I go with the pathology. I thought like physiology was more like some boring subject.
Boring subject.
Yes,
All right. Okay. Why?
I don't know, ma'am, but pathology,
All
I think
right.
it was for me, but
It's
in
interesting.
my mind, physiology is yes, ma'am.
It's very boring. Okay. Jyoti, what do you think?
Ma'am, pathology over physiology, because physiology only deals with the normal stuff, ma'am.
No,
Every
physiology
day,
deals with the normal stuff. So there, now you have come
normal.
to something very interesting. Okay. So you think that something that's normal is really not worth even knowing or studying, or do you
Ma'am, it's
think
very
you could?
bad.
Do you
Very
think
bad.
you can do pathology and do it successfully without knowing something that
Nice
that
for
is
that,
normal?
but as a career, I don't felt like doing, ma'am.
You didn't feel like doing it. What about
Yes,
Mansi?
ma'am.
I think Mansi has disappeared, or she's there, or she's lost her her internet, or whatever it is. Avinash,
Yes, ma'am.
would you have ever been ever taken up physiology?
No, ma'am.
You would not have. What do you think of somebody who is a physiologist, who teaches physiology, or any other person whom you know who has done physiology? What do you think of them? Do you think that they're boring? Like, I don't know, who said it was boring? Dharani or Aarti or somebody? What?
Me, myself.
Aarti, you said it was boring?
Myself.
No, ma'am.
Mm. Okay, so Dr. Mansi is muted. If somebody can unmute her, please. Yeah, so what, Avinash, do you think your physiology teacher was boring?
Not boring, but
Not boring? Okay. Was inspiring?
no, it's
No?
a pure non-clinical where you don't get interaction with patients or not doing anything about the treatment or
I see. So you went into medicine really to have interaction with patients. Okay, so good. All you guys have answered these questions, and I'm getting an idea as to why. I mean, what is the kind of reasons that you have chosen something? And it seems to me that if you couldn't get something that was clinical apart from dermatology, because somebody also said that dermatology is again very boring because everything looks the same. Okay, so to me, it almost seems as if pathology is sitting somewhere between clinical medicine and, as somebody said, a paraclinical side. I don't think that in medicine there is anything that is paraclinical. Not anatomy, not physiology, not clinical biochemistry, not pharmacology. they are all clinical as far as I'm concerned. Okay, because I don't think that that they are not of any use in clinical medicine. Okay, so somehow or the other, people have got around to feeling that there are some things that are clinical and some things that are paraclinical. And unfortunately, I think that a lot of people have got the idea, and when I say a lot of people, I mean those who are studying medicine, that there are things that are paraclinical that we do before we go to the wards, and there are some things that are clinical after we go to the wards. Okay, but I think if you really think about it, there is nothing that is non-clinical as far as this is concerned. Yes, there are things that you deal more with, with patients, those who are ill. But everything that you do, and that is something that you have to realize, that you go into medicine not only to deal with those who are ill. Okay, Mansi, do you know of any branch that you deal with? Oh, it's a medical branch. Yeah, where patients are not ill. Yet you deal with them.
No, ma'am. Like
No, Mansi,
all
can't
branches
think.
have to, deal
All
with
branches where patients are sick or ill or have quote unquote a disease. Yes. Yeah, anybody, you can write it in the chat box. Somebody has said, Vasudha Bhagat has said sports medicine. Very good answer. Okay, sports medicine, you don't have to be ill. Okay, you can make somebody reach peak performance. There are lots of things. They're not ill. Okay, and you know that one of our wrestlers, I think it was a wrestler, if I'm not mistaken, who was denied the, yeah, there you are, obstetrics. I don't think that the person is ill. Is the person ill, Mansi? See, lots of people, preventive medicine, obstetrics, cosmetic medicine, they're not ill. Okay, sports medicine. So I think that we now have to get away from this idea that we're doing physiology. It's got nothing to do with patients. Anatomy has got nothing to do with patients. What is all this? And pharmacology. Yes. Pathology. Yes. But all clinical biochemistry, etc. And it is, a lot of it deals with understanding what is normal, okay, and helping patients who are otherwise perfectly normal to get either a better outcome of whatever it is, like in obstetrics, or really reach their peak performance if they are in doing sports, or if they are dissatisfied with the way that they look. All right, somebody has got a very hooked nose and is being made fun of, etc., and somebody wants to have cosmetic surgery. Now, do you think that that is about being diseased? I don't think so. Okay, so I think there's somebody who said something very nice over there, that pathology deals with all branches. Yes, it does. Okay, for that matter, so does physiology. I don't think physiology is only dealing with something, or is clinical biochemistry, anatomy, and everything else. All right, so we have to disabuse our ideas of why we went into medicine. Of course, you may have your personal reasons as to why you went into medicine, but a lot of people believe that medicine is about curing people of some kind of illness or disease or discomfort, whatever it is. It may be pain or whatever else. Okay, but remember that this is not always so. And I'm really very happy to see that once you start thinking, you'll come to a deeper understanding of what it is that medicine is all about. All right. It's too much to go into the etymology of what the word medicine actually means, but it is. Now, there is this last question. I mean, I'm only going to ask you, is there one subject that you would never have chosen? Because we've already talked. Maybe you would never have chosen physiology or something else. Anything, any one of you wants to add one subject that you would have never chosen and you would have gone on and on taking your NEETs and whatnot? Yeah? Aarti, what would you have never
Pediatrics,
taken?
ma'am.
What?
Pediatrics. Pediatrics.
Pediatrics you would never have taken. Oh, very interesting. Why? Because it's like veterinary science?
Yes, ma'am. Actually, we don't know what they are coming to say. So you should
Okay,
tackle the patient before.
Mandeep Singh says forensic medicine. Okay. You have, Mandeep, do you ever watch that, sort of serial which is called CSI? No? You should watch it. Then you'll know why you want, why you would want to do forensic medicine. Okay. Somebody says they would never have done surgery, etc. Okay, yeah, Mandeep has not watched CSI, then you should. Okay, so anyway, I think we have done our preliminary little kind of investigation as to why you did medicine, why have you done pathology, and I think why pathology, as I said, is a very good question and it has a very good answer. Okay, and what is that answer? Somebody says I like it, somebody says, oh, it was chosen for me, I didn't get it in my, the computer did not choose it, there were so many people and counseling was this, that, or the other. I have a very good answer to this. Can anybody guess what is that very good answer? And the very good answer is this: why not? Okay, I honestly do not know why pathology is getting such bad press. And I honestly think that, people say I want to do diagnostics. Yeah, because now diagnostics has got a better name than it had once upon a time. But a lot of people are becoming more and more pragmatic in the sense, I'll never get pediatrics or I'll never get medicine, I'll never get surgery because, they're hard to get. Only people at the top of these exams or whatever ranks will get it. So why don't I choose something where I'm more likely to get it? And I just think that you have to really, really give me an answer to this answer. Okay. And that is, why not? Okay. When you stop to think about it, physiology is the basis of medicine, of anything that you do in medicine, whether it is about illness or it is about doing things where people are not really ill, but they require the services of somebody who is a doctor. That's what we do medicine for. And if somebody is ill, then pathology is the soul of medicine. Because by and large, whether we're doing obstetrics or we're doing sports medicine or we're doing cosmetic, so there is always, in each of these branches, there is a lot of normal, but there is also a lot of abnormal. And pathology is really understanding the normal to understand the normal better. And I don't understand why this aspect of pathology is not communicated, during your formative years in medical school. Okay, and I'll tell you this: all good clinicians value good pathologists, and I'm using the word clinician in the way that most people understand it. But let me tell you that I am a clinician first and last. I could not be a good pathologist unless I were a good clinician. Okay, and I will give you an example that happened only this morning. I have had a cataract surgery, so I cannot look at slides. Okay, I cannot use a microscope temporarily. And somebody was interested in getting some report. And I phoned up the lab and I said, what is the report on this so-and-so person? And that so-and-so person was like a 55-year-old woman. I only knew the name. And the lady who read out the report to me in the lab said that it's ready, the report is ready, and it is called a small cell carcinoma. Okay, I don't know if there are, there must be. I know that I could see the names of some people who have passed out in pathology. Many are practicing pathologists, okay? And when I heard that report, that here is this 50-something-year-old lady, it's a biopsy from the lung, and it is small cell carcinoma, I called up that clinician and I asked one question, okay? And you know what is that one question that I asked? If anybody can just put it in the chat box. I don't expect where, okay, I don't mind if Mansi or Jyoti or Avinash or anybody can think of that one question. If you know something about small cell carcinoma, somebody is saying symptoms. And yes, there is somebody in the chat box who has said, does she smoke? Is she a smoker? Okay. And I rang that clinician and I said, this is the report that somebody has given in my lab. I don't have any reason to doubt it, but I need the answer to this question. Is she a chronic smoker? And that guy said, yes, she's been smoking for years. In fact, she has been my patient for a number of years for chronic obstructive pulmonary disease. Now, this is where we are clinicians. I am a clinician. I would never make a diagnosis in a female patient if of a small cell carcinoma if that patient was not a smoker, male or female, but males may have industrial exposure to smoke or whatever else. Females, by and large, do not. And I would have asked for a review of such a diagnosis if I were a clinician and I received that diagnosis, and I would not make that diagnosis unless I had that history. Okay, so a good clinician will value a good pathologist. And I'll tell you this, all good pathologists are good clinicians. You cannot be a good clinician, pathologist, unless you are a good clinician and you know a lot about clinical medicine. Okay, so once again, I'm asking you this question. Why not pathology when it encompasses so much of clinical medicine that every day of your life, whether you are doing clinical pathology or you're doing hematology or you're doing anatomic pathology, you're doing molecular pathology or anything else, there is a clinical component to all of your diagnostics. To some extent, that is also true of radiology. But quite often radiology, or they're doing fantastic things in radiology these days, radiology is still relatively tentative. Pathology is getting less and less, and by the word tentative, I mean still has there may be some little difference, or they may not be able to say for certain. As pathologists, whether we're saying that this is a value in clinical medicine, or this is the cause of the anemia in hematology, or I'm making an anatomic diagnosis, a histopathology or a cytopathology diagnosis, or I am looking at a molecular or a fish report or whatever, there is nothing, or there should not be something tentative about it. Okay, I don't write disclaimers underneath. my report. Okay, so this is why I emphasize the answer to why pathology is why not. Okay, we are clinicians first and last. And you know, everybody is talking diagnosis, diagnosis, diagnosis. Please understand that today pathologists increasingly, no matter what branch of pathology you're doing, okay, increasingly contribute to medical management. Yeah, about how should this particular individual be treated or managed better. And this is just not diagnosis that we are doing. And the faster that we realize this, and unfortunately, of course, we don't realize it until we are well into pathology. And maybe there are many people who are doing clinical medicine today, what we call clinical medicine, would have made really fine pathologists if they realized that this was not just about making a diagnosis. I really want to work with patients. I want to, sort of manage them better. I want to treat them better. Hey, there's no reason why pathology cannot do this. Okay, it's important. And this is, I know that this word team is overused. Everybody is a team. I'm a part of a team. You're not an individual. You know, as they say, I is the one letter that is missing from the word team. All those things are very good in corporate culture, but here it is absolutely so. All pathologists are an integral part of a team. And this is something that I feel that all of you who are now embarking on this career in pathology, and those who are all already practicing pathology, think of yourselves not only as pathologists, but think of yourselves as clinicians. Think like a clinician, okay? And then pathology just becomes a second nature to you. So now let's ask this question. You know, since pathologists and clinicians, really there are no boundaries between the two. What is it that pathologists and clinicians have? What should they have in common? And if there is something, and I think that's two things that they should have in common. Anybody who wants to be a good professional, whether you're a pathologist, you're a clinician, you're a radiologist, if you're not even doing medicine and you're doing something else, if you're in science, if you're doing history, whatever it is that you are doing, yeah, there are two things that you require. One is curiosity and the other is passion. Okay, so what is curiosity? I think curiosity is not just, I want to know something. No, it's not that. It is a strong desire to know or to learn something. Okay, and the strong desire translates as passion. If you have a strong desire for something, then you have passion, whether it is for music or it is for films or it is for reading or for anything else, for whether it's a hobby or it is anything. If you have a strong desire, then you have a passion. And if you have passion and curiosity, there is nothing like it. And if you want to be a good professional, and all of you have taken pathology, some of you have taken pathology because it was chosen for you, all right? Some of you, like, I think it was Dharani, or was it Aarti? I'm not sure, who was asked to do OBGYN, but she gave it up and thought that pathology was a much better thing. And somebody like her will have a passion, okay? It's difficult actually to work up a passion. If you know something well, then it's easier to develop a passion for it, okay? Because there is one thing that I have found as a teacher, as a learner, that without passion, learning can be very difficult. Then things will be, as some people have said, boring. Physiology is boring. All right, there are two parts to that. One is the teacher, the other is the learner. So if the teacher does not work up a passion in the learner, it's very likely that the learner is not going to be able to learn and will consider that this thing is boring. Okay, now see, there are different kinds of curiosity, and actually there are treatises that have been written on curiosity. But we all have what is called perceptual curiosity. And you know what that is? I see two people always going out together. Okay. These days, I hesitate to say that it's a boy and a girl. Today, I see boys and boys, and I see girls and girls. Okay. And you are dying to know. See, this word dying to know. What is the relationship between those two? Are they a couple? What is it that, and sometimes you may be entirely wrong. They may be just brother and sister and they're just going home together. That's a different story. But when you feel that, oh, I must know about this, that's passion. Okay. And this is called perceptual curiosity. It is stimulated by novelty, strange, puzzling phenomena, but it is very, very temporary. Okay, it's only some specific events. Oh, look at that, I'm seeing something in the sky or whatever else, and I wonder what it is. But that passes off. But there is underlying in all human beings, and we are Homo sapiens, right? And Homo sapiens, I hope you know that we belong to the genus Homo. We are all animals, and we belong to the genus Homo and the species sapiens. And sapiens means knowledge. That means the Homo, or the other word, man, who thinks or who wants to know. So if we are Homo sapiens, all Homo sapiens, the whole genus has been able to spread all over this world and do fantastic things, go to the moon, do all sorts of things, which lots of our other animals on this world, some of them may have better eyesight, some of them may have a better sense of smell, some of them may be able to hear things that are beyond the capacity of the human ear. So in individual ways, many animals have got skills, attributes, etc., that far outweigh our own. But as a species, as a genus, we have combined with all our attributes, all of them not matching up to many others. I mean, look at even in the matter of strength and speed and hearing and eyesight and many other things, we may fall below that of individual other animals. But altogether, we have outstripped the other animals in terms of what we have achieved. Okay, we have achieved music, we write poems, we do all kinds of things which other animals are not able to do. So there is, what is at the bottom of all of this? It is this desire to go beyond what we know at present. So it's this desire for knowledge in a general sense. And this knowledge, this search to investigate nature, which we call science, but we investigate nature in many ways. We investigate it as science. That's what we do. We may want to investigate it from the point of view of philosophy. We may want to investigate it from the point of view of, who made us, to question why am I here? What is it that I have been sent on this earth to do? Every day we don't ask ourselves these things, but as a species we do. Okay, so I just want to tell you here, look what Albert Einstein says. And I don't tell me that Albert Einstein is not a person to be taken, lightly. And what did he say? I have no special talents. I am only passionately curious. So that is exactly what I said, right? If you have curiosity and you're passionate about what you do, then there is no limit to what you can achieve. And Albert Einstein actually did that. Okay, and now I want to tell you about how we can use our curiosity. Okay, because this is important. And if you have curiosity, somebody when we were chatting saying that they wanted to, or they thought that what I was going to talk about is how or why did I take up pathology? Yes, I will talk about it. Okay, but I just want also to show you how you can be a better whatever it is that you are. If there were clinicians, then they would also be able to take something from this. All right, so I'm going to take this autopsy case, and maybe I can ask somebody. Avinash, you wanted to do pathology, right?
Yes, ma'am.
Come on, read this autopsy case, and I'll ask you a question at the end of it. Come on. It's a real case, huh? Because I was supervising that autopsy.
46-year-old male.
Yeah.
Presenting with severe cachexia,
Yes.
obstructive jaundice. Clinical diagnosis is carcinoma of the head of pancreas. His bilirubin level was 16 milligram per deciliter.
He died. He died.
He died,
Yes.
and 20 minutes after CT scan for staging. Cause of death: carcinoma pancreas with obstructive jaundice.
Yeah. So now can you tell me what this story is about in a nutshell, Abhinash?
Yes, madam. It's a pass.
This was a
Cause of
patient
death.
who had a carcinoma in the head of the pancreas. No, I mean the
Yes,
clinical
madam.
diagnosis was that he
Yes,
was
madam.
severely cachexic. Now, what is cachexia?
Weight loss, severe weight loss.
Severe, that means he's skin and bones. Okay, that means you have very severe, and it's not just weight loss, but you're sunken, your cheeks are sunken, your eyes are sunken, you've got hardly any fat left anywhere in your body. He's got a very severe bilirubin. Okay, I say very high bilirubinemia. It's 16 milligrams. All right. And he came to have a CT scan for staging. Now, what is the meaning of that, Avinash?
Yes, madam.
What is that? What is a staging?
After the
CT
CT
scan
scan,
for staging? What is the meaning
it
of
is a
staging?
radiological. It is a radiological staging, not.
Yeah. But
done
what is
after
staging, Avinash?
staging is whether it is already metastasized to other organs or confined to only that head of the pancreas.
Yes. So what staging is about how large is the tumor and where has it spread. Okay. So those are the two usual dimensions that are used for staging. So is it confined only to the pancreas? How large is it? Because it might have maybe a small tumor which has blocked the bile duct, and it may be small. It's not spread beyond the pancreas. But you're right. That's what. So they're doing the staging because they want to know: is he a suitable case for surgery, or has he got a cancer that has spread beyond the pancreas? Has it involved the portal vein? Is it metastasized, whether to the liver or to the lymph nodes, etc. That is why he came to the hospital. Yeah, and 20 minutes after his CT scan for staging was over, he was sitting in a wheelchair and he died. Now, obviously, since there was death in the hospital, okay, he was not admitted. All these kind of deaths have to be informed to the coroner, and the coroner usually says, do an autopsy. So the autopsy was done, And the cause of death was given as cancer of the pancreas or carcinoma of the pancreas with obstructive jaundice. Okay, so now is there anything missing in this, Abhinash?
Yes, madam.
What are you curious about? What are you curious about?
During CT scan,
Uh,
is anything wrong happened to that patient?
What happened? What went wrong with this this cause of, I mean, during CT scan? You think that something might have gone wrong? Okay, so somebody
ma'am.
saying cause of death in the chat box. So Sonali saying, could it be contrast dye? Okay, somebody saying stage of the cancer, pathological. So what is the actual question that you're asking, Avinash? Huh? Yeah,
Yes,
that's
ma'am.
the question,
Why the
right?
patient died of the CT
So
scan?
there is a why question there. Why did this patient die after a CT scan? Okay, when he arrived unaided to the radiology center. He came. He was, yes, he was had cachexia. He had a high bilirubin, so he was jaundiced. But he came unaided to the radiology center. So that is the question that had to be answered. And an autopsy was done. And all that the autopsy showed was that there was a carcinoma of the pancreas that had spread beyond the pancreas. And that's why he died. Now, does that satisfy you, Avinash?
Not the immediate cause of death, Elena. Sorry.
So somebody wants, yes, who said that? You want to know what is the immediate cause of death? Exactly. So we knew that this patient had carcinoma of the pancreas. I mean, they knew that. They were only doing the CT scan for staging. Okay, so we had to be curious. Why? Why did this patient die? All right. So what are the causes of acute, death? Was it an acute cardiac death? As time had come, he was anyway dying of cancer of the pancreas, so he just died like that. We had to know what actually happened to him. Okay, this is the curiosity, and it did not have to be a pathologist who had to be curious about this. If I were a clinician and such a thing had happened, I would also be curious as to why did this patient die when he went there happily. And as somebody said, did he have an anaphylaxis to the dye that was injected? What actually happened to him in that CT scan room? Okay, yeah, I think that the clinician should have been curious about it at all. But what do clinicians do? Chalo, do an autopsy. Okay, and the autopsy showed nothing but a tumor in the head of the pancreas. Now I tell you, I don't leave these things as they are. I'm a curious person by and large. Okay, so I went to the CT scan room and I began questioning people over there. And you know what I found? Here it is. This particular case was used for calibrating a newly installed CT scanner. So the CT scanner was new and they were calibrating it. And you need a patient to be in that room to calibrate it. Okay, at least in those days they did. The room temperature in the gantry room was 14 degrees centigrade. This man who was already low fat, okay, had a single thin blanket that was provided to the patient. And you know where we are going now. The procedure took 4 hours because this was a calibration thing. And the patient was moribund. Moribund means almost next to on his deathbed when the procedure was over. He could no longer get off the CT, table, and he had to be helped into a wheelchair. By the time he was helped into the wheelchair and just taken out, he was dead. Okay, so now everybody knows what is the cause of. Come on, Abhinash.
Yes.
What did he die of?
It was
Yes,
hypothermia.
Avinash?
Hypothermia.
Maybe hypothermia.
Yes, he died of hypothermia. He had hypothermia in a severely cachexic patient with, of course, why was he cachexic? That was okay. He had a pancreatic carcinoma and obstructive jaundice. Now, this is not something that, as a pathologist now, that you suddenly dream of by looking at in the autopsy room that this man is in a patient in the autopsy room has already been in the morgue for 2 hours. Okay, his body temperature is already low. So you are not going to be able to know unless you know the circumstances that happened before as to why and how this patient died. Now, what is the moral of this story? You have to be a good investigator. You have to be almost like Sherlock Holmes. You want to know why this patient died. And somebody who said, I would not do forensic medicine, okay? I think that forensic medicine can be one of the most, what would I say, satisfying branches because you're investigating. And what is diagnostics? What is clinical medicine? If it is not investigating for a cause and then treating it. So whoever said forensic medicine, here is a case, okay? This is forensic medicine. We discovered this, and then after they not only were they giving patients very thick blankets, but they disconnected the air conditioning, which was used for the all the computers and other things, which require to be kept very cold, from the gantry room where the patients are usually kept. So we made this autopsy was done. There were no morphological findings, but here was the cause of death. All right, we'll take another autopsy case. Okay, now, Dharani, you wanted to do pathology, right? Dharani? Are you there, Dharani? She's disappeared.
Hello.
Yes, Dharani, come on, read this.
Nice, ma'am. Yeah, 46.
You want an
Reveal
annotation
a direct,
request? Yes.
direct laryngoscopy under
Dharani,
anesthesia.
I've lost
Procedure
you.
took
Come on.
15 minutes. Ma'am, can you hear me, ma'am?
Yes, I can. We
Ma'am?
can hear you. Thank you.
Yes, ma'am. Yes, ma'am. Direct laryngoscopy under general anesthesia. Procedure took 15 minutes. Was fully awake, being used to the ward. Died in the lift. No morphological cause found to explain the death.
So now, come on. What is your curiosity now in this case? We've done the autopsy, and if you have attended autopsies, I don't know, Dharni, if you have, or those who have attended autopsies, quite often we don't know. There is no specific reason. Even an acute cardiac event may not show you anything in the autopsy. You may not find a fresh thrombus. You may not find anything. Okay, so there's no morphological cause found to explain death. So what should we do now, Dharani?
Actually, a patient undergone laryngoscopy. Maybe any vagal overreaction or cardiac
overreaction. All right. So
cardiac.
now we know that this is short general anesthesia. Okay. It took only 15 minutes. And the patient was fully awake. Was being transferred to the ward, and he died suddenly in the elevator. That is the lift. Okay. So the question that we have to ask, okay, why did this patient die suddenly? You just can't say I did the autopsy and there was no morphological cause found. So now it means that you have to do an investigation, okay? Investigation into the causes of sudden death. Somebody saying aspirated blood. Okay. So what are the causes of sudden death in which you don't find any morphological findings? Yeah, Dharani, come on. We have to be clinicians now. What are the causes? Anybody can tell.
Cardiac cause.
Somebody is saying cardiac arrhythmia. Very good. Somebody is saying laryngospasm. Very good. Somebody is saying claustrophobia. Okay. So come on. Yes, Dharani.
Ma'am, I go with cardiac arrhythmia, ma'am. It will be
Yeah, no,
the
but what
sudden
are the
cause for
causes?
this.
Then we'll have to try to figure it out, no?
Ma'am,
And we can't
muscle,
figure. We've done the autopsy, and we have not
ma'am,
figured
muscle
it out.
relax.
So these are all the causes, no? And this is something that if you are doing an autopsy, your job is not only to go there and see, are there any morphological findings? Oh, can I see that, there's a clot in the pulmonary artery? Is there we have to actually, or as somebody said, aspirated blood. Hey, if we had aspirated blood, I would have seen it. No. So was this an acute massive myocardial infarction in which there was no thrombus that was found, which you may not see it, and you may not see a blanching of the cardiac muscle or anything. Blanching meaning it's gone white. Cardiac arrhythmias, yes, somebody said that. Sudden laryngospasm can happen because they had intubated it in him, and they were looking into that larynx. Okay, drug reactions. It could have been, was it anaphylaxis? Okay, because they give you drugs. Poisoning is one cause, but now nobody is likely to have poisoned him, or somebody paid the anesthetist to poison him. I doubt it. This was not a supari of some sort. Yes, it could be hypothermia, but not in this circumstance. And positional asphyxia. It's possible if somebody is not looking at him and his face is turned and he's buried his face in his bedclothes or in a soft pillow, and maybe he's asphyxiated. I don't know. So we had to figure this out. All right. So you have to question the people who were there in that lift while he was being transported. Okay. And so when the attendant and the nurse was asked, that attendant said nothing particular. He just gave a little gasp and he died. Okay, so he didn't vomit. He didn't, sort of get a sudden bout of breathlessness. Didn't he was fully awake. He didn't clutch his chest or anything of that sort. So now we had to go and look at his notes. And what did we find? I said, I want to see all his notes. And you know what I found? That what they had sent along with the body was just a thin sheet, thin lot of notes. When I said I want to see all the notes, then came a big thappa. And you know what I discovered? Just see, the patient was an old case of cancer of the larynx. He had had 2 previous major procedures under anesthesia, 2 years before the present procedure. On each occasion, the patient had suffered attacks of ventricular tachycardia, which were detected because the patient was being monitored under anesthesia, because he had major procedures. This time, it was a minor procedure, so he was not being monitored. That means they didn't put on, this day and age, they put on pulse oximeters and other such things. In many, many places, they do not monitor patients under anesthesia, minor anesthesia. You do little dental procedures, you do things in very short anesthesia where, nothing is really done. And this present anesthetist was unaware of this history because she didn't have all those notes. She just had the present notes, which were a small thing saying, patient to have this procedure under short anesthesia. And this was a minor procedure and it was assigned to a relatively inexperienced individual. So what is the cause of death now, Dhanani? What's the cause of death?
Myocardial
What do you think?
infarction or
Ventricular tachycardia.
Yes. Sorry.
Ventricular tachycardia.
Yes, it is uncontrolled ventricular arrhythmia, which was related to the anesthesia. Okay. So yes, somebody said something about vagus. because that is one of the causes of cardiac arrhythmia, particularly under anesthesia. So, what is the moral of the two stories that I told you? This is not great diagnostics. Okay, this is essentially an investigative procedure. Okay, somebody saying past medical history. Okay, Mansi, are you there? Can you tell me what is the model of these two stories? Mansi has disappeared again. Seems like it. Jyoti, are you there, Jyoti? Jyoti's also
Yes, ma'am.
disappeared.
Yes, ma'am.
Yes, Jyoti, come on. So what's the moral of these two stories? What is it that I'm trying to tell you? But my talk today is why pathology. So what is this? Is there a moral to this story? You don't understand what is the meaning of a moral of the story, Jyoti?
Yes,
Have
ma'am.
you
We
heard
should
that
go
term?
with
Yes, ma'am.
Yeah.
Yes, ma'am.
So what does it mean?
Ma'am, there is nothing like non-clinical, paraclinical. Everything is related to clinics. You can diagnose.
Everything is clinical. Okay. And pathology is so all-encompassing. You are asked to do an autopsy. Everybody thinks that autopsy means finding the anatomical cause of death. That's not what an autopsy is. That's not what any of what pathology does. That is not the beginning and the end of pathology. Okay. It is about understanding what this is all about. And I want to tell you that it was a surgeon, and this surgeon was a neurosurgeon whom we all used to fear, not when when we were in the third MBBS, but as pathologists, we feared him because he was the only surgeon who would attend every one of the autopsies of his patients who had died. And when he came, he used to be very cutting in his remarks, his questions. In fact, he was not a very pleasant individual. And I must tell you that I was doing my first, maybe it was my second autopsy, I can't remember. And it was one of this doctor's cases. And this guy had died of post-operatively. He was there in the ward for about 4 or 5 days, and he died of acute meningitis. Okay, I mean, it was a classic case of acute pyogenic meningitis. You could see the pus all over in the meninges. You could see beautifully. I mean, I know it sounds terrible to say beautiful, but that's what pathologists are. You could see the pus that was present along the sagittal vein and at the base of the brain and everything, And I knew that this was Dr. Daftari's case, and that I was hoping that I would finish this autopsy, lay out all the organs, and buzz off before he came. But that very seldom happened. And he arrived with his whole phalanx of residents and senior registrars and assistant surgeons and everything. And they used to stand behind him and snigger because they knew that the pathologist was going to have a hard time. Now, when there is a system, when somebody comes and you say so and so, the name of the person who had died, and you say it was a 40-something-year-old male who had this, that, and the other, and the cause of death. And by that time, he had picked up the forceps, and he had a way of shaking his head, which is called titubation. So he said, no, doctor, I don't want to know why he died. I want to know why he lived so long. And there is no answer to that question. At least I didn't have an answer to that question at all. And all of the others who were standing behind him were, big grins on their faces. It was very obvious that this man had died of acute pyogenic meningitis. It was a post-operative infection. And he just deposited that forceps and he walked out of the room. And I was really, really hopping mad. Because here, you know, you had everything laid out, everything. You knew the cause of death. There was nothing left to be done. And this man asks me a question, which I didn't know the answer to. Okay. So anyway, you know, I just wrote up the notes and everything, and I went up to have a shower. And while I was showering, and I was furiously thinking, now I should have had some answer, even if it was a very sarcastic answer to give him, when it suddenly dawned on me that what he had asked, I didn't even know whether he was, this was in his mind, but it suddenly came to me that what he had asked was such a fundamental question to me as a pathologist. And what was that fundamental question? It is, all right, you are seeing death and all the findings at one point in the course of this disease. It may be the final point in the course of this disease. But this disease has been dynamic, and there have been other time points in the evolution of this disease. And that is really what should drive you as a pathologist, as somebody who's doing medicine or anything. It's not about one time point, one diagnosis. It is about understanding normality and disease in a dynamic fashion. And then thereafter, all my resentment against this question and Dr. Daftari in particular just melted away, and it changed my life. And many years later, when I met him, of course, he was a family friend, etc. And I told him, I said, you know, Dr. Daftari, you changed my life. He said, really? And I told him the story, and he said, oh, I was not thinking so deeply. I said, I know. But because I was thinking of some repartee or some answer to your question, I got something out of it. Okay. And you know what I found when I went back to the organs? Of course, you take organs and you take bits and pieces for histology. You know, you could see everything. You could see what had happened to the kidneys. You saw how the lungs shut down during sepsis. You could see everything, including the primary disease for which he had opened his, opened the cranium. This guy had had a glioma or something like that. And everything was seen in little snapshots over a period of time. And I believe you me, it has changed my life. So I think that we have to look at medicine, we have to look at pathology as something that is dynamic of how a well-oiled system, that is the human body, what happens to this human body after it has undergone certain changes, normal, or that means physiological or non-physiological, and how the body reacts to these changes. Okay, I think I'm being waxing eloquent, but that is the passion that I feel one has to bring to this subject. Okay, so just to say again, what is passionate curiosity? It's not just curiosity. There are three questions. It can be what, it can be how, and I believe that just answering these questions or teaching to the what and how is training. When you add the why question, then you are being educated. And I want all of you to be educated and not just trained. Okay, training is a very bad word that has come from America. Everybody is trained, but are they actually educated. All right. So you have to ask why questions. Why did this patient die? I was expecting this patient to die, and lo and behold, the patient is still alive and well. Why? Okay. Is there something I can learn from this particular situation? Okay. So I say that the why question is what drives diagnosis and learning in medicine. Okay. So now let's come to this thing. Okay. If I say, we talked about it, why pathology? Why is this question actually being asked? When I just shown you that pathology, when I say why not, when pathology is such an engaging, such an, to me, exciting exploration of normal and abnormal, okay? And this question presupposes that very few opt for pathology by choice. And I think that by and large, that is true. Okay, there is a bias in how people answer questions. I have stood on a stage and asked people in the audience, how many of you have taken pathology by choice? And I can tell you that if you have about 100 people over there, not more than 10 or 15 hands go up. I think we know that most people believe that pathology is a profession that needs marketing or motivation. Otherwise, nobody wants to take it. Lots of people opt for surgery or internal medicine or orthopedics or any of those clinical branches. So when you ask why pathology, it means that there's a problem there. You have to market pathology or you have to have motivational talks. Otherwise, people don't want to take pathology. And some people have answered this question. They've said it is not as exciting a discipline as surgery or medicine. And somebody actually said it about physiology, but a lot of people think about it, think the same way about pathology. It is downright boring. And somebody did say it is a dependent branch. Now, I don't understand what is a dependent branch, because everything is dependent on everything else. And I think what that person actually meant is that it is a financially dependent branch, in the sense that at least if I am a clinician, I can set up a little shop somewhere. It doesn't take, shop meaning I can have a consulting room, and it doesn't take anything more. I do not require investment in machines or in a microscope or in anything. So maybe that's what is meant by it is a dependent branch. And somebody also mentioned this. There is stiff competition from non-medical practitioners. And I think what they mean is DMLTs, those who are medical laboratory technicians who set up branches, little labs, or even those who are not MDs but who have diplomas, etc. And there is competition between them. And again, it is about financial, competition. And this I have heard, not from any of you, but I hear it all the time, that the social status of a pathologist is lower than that of a clinician. And I just say that the social status of, if you have gone into medicine, okay, where is the question of a social status? You are already in the creamy layer. And once you are in medicine, it's not as if you are doing something that is considered a socially low profession. Okay, you're not somebody who has no other choice. You are already in the top. Now, if you are going to sort of stratify, oh, at the top of the heap is a neurosurgeon, at the next thing is a cardiac surgeon, and so on. I think then this is, we are being more casteist than we should be. All right, and I think that's ridiculous. I'm a pathologist. If I hold my head up high and I'm a good pathologist, I don't think that my social status will be any lower than that of any clinician. Anyway, that's my feeling, but I know that lots of people have said this to me when I have asked. Okay, so again, we have to ask, why is pathology so low down on the list of choices for PG courses? I gave you some answers in the previous, but those are things that people don't normally I mean, they think about that, yes. But have you thought, about the why not? And I think some of you have actually given me the answers. Okay. So somebody said something about we report on invasive procedures. Yes, we do. I think that pathology has a very bad, not very bad, but like people say, I never do physiology. I'll never do clinical biochemistry. Okay, one of the things was that this is out. Nobody tells us what is the context of physiology or clinical biochemistry, anatomy, or like somebody said, forensic medicine. In the context of medicine. And I really think that pathology is not put into the context of or the exposure that medical students have to pathology. Yeah, and a lot of it is the blame has to be on teachers in pathology. A lot of people, find that it is taught to them in a very dry and theoretical kind of way. And you go to these museums and you see these things in glass jars, and you're given some, you go and sit in central lab, and a lot of people are collecting blood, and you're looking at things on. But really, it is done in a very dry and theoretical kind of way. And I blame pathology teachers to a large extent because they are role models who do not have much real world experience, because most of the pathology teachers in medical colleges are full-time teachers. Okay, they should be exposed to the hustle and bustle of pathology that occurs in a teaching hospital that is attached to but for some reason or the other, when people say, what is it that you want to do? I want to go into academics. And I know what they mean by academics. It's got nothing to do with research. It has to do with, I will sit and do teaching in a medical college. But those teachers do not expose medical students, because they are teaching second MBBS medical students, to the real romance of pathology. How a patient would not get the benefit of good management, good diagnosis, if it were not for pathologists. Okay, you know that the labs in the majority of teaching institutions are very unglamorous. Yeah, you don't see all the nice shiny machines and other things that you see in private laboratories. And I sometimes feel that, all medical students should be exposed to the kind of pathology and the glamorous equipment that is seen in the private colleges. Maybe I can ask, these students. Ajay, had you ever seen a private lab?
Not on the inside, ma'am.
Sorry?
Not on the inside, ma'am. Never.
Not on the inside. Yeah, you never went in during your second MBBS. Were you taken to a lab where you saw full automation? You saw all of that?
No.
Yes.
The
Ajay,
most we saw were like 3-part or 5-part analyzers. That was it.
you saw 3-part and 5-part analyzers. That's good. Okay. How did you do sugars?
Sugar was
In
mostly
third
like
MBBS. I'm talking about second MBBS.
sugar was sent to biochemistry or like in the ward itself at the glucose.
Yeah, but you must have gone there and seen how sugar was done in second MBBS, right? No? You didn't even in second MBBS? Come on, Aarti, how was a sugar done in second MBBS? Aarti?
Ah, yes, ma'am.
Yes.
Think,
How did you do a sugar? No? You didn't do? Okay. Did you do urine sugar?
Benedict solution.
Benedict. Yes, very good. And today, if you have to do a sugar, urine sugar, what do you do?
I'll use the strip, ma'am.
You do use the strip. So this is what I'm saying, that there is nothing that, and heating the albumin and showing you that there's a heat ring, you have to heat it near the surface and all that kind of story. I mean, it is biblical era labs that to which second MBBS students are actually exposed. And no doubt that there are maybe even in your postgraduate degree, depending upon when you're doing your postgraduate training, depending upon what medical college you are in, you may not have really good path labs. I hope you do, but maybe you don't. All right. There's also a very poor understanding of the scope of pathology to second MBBS students. You have no idea what it is all about. So, but you do know that surgeons open and close abdomens and so on. You have a good idea of obstetrics and gynecology. You see orthopedic surgeons doing things, and you find all of that glamorous, and you don't know what pathologists actually do. Okay? I can tell you there's better PR, public relations, of all the clinical branches. They don't go out to do public relations, but the very fact that they strut about the place and so on. And if you are in one of those medical colleges, which also have, of course, there are full-timers who are attached, but you also have part-timers who are attached who do private practice in other institutions. There are medical colleges who have a mix of full-timers and private practitioners who are teachers in medical colleges. You know that the ones who are full-timers have got, they come, they either take the bus or the train, or they have small cars. Okay, some of their students have got better cars than they have. Yes, and that's what I mean by the PR. Okay, they just by the way that the glamour or that they exude, they have better PR. And then, see, there were two people here who wanted to do radiology but settled for pathology. Okay, and that is the draw of the men and women behind big machines. All right, the CT scanners and the PET scanners and the ultrasonographers, and also surgeons and others who have other big machines like the BMWs. Okay, so this, I think that if we could do better, and I'm talking to pathologists in general, you guys have already opted for pathology. Okay, so all that you need is motivation to be better pathologists. Yeah, but if we want to improve the number or the proportion of medical students who opt for pathology, then I think we have to do a better job when we are teaching medical students, and we have to show them how pathology or what value clinicians put on pathology, and how pathologists can really integrate themselves into the team that is managing a case. Okay, I don't think that there is enough of that kind of motivation. Okay, so what is the scope of pathology? I think you all know the scope of pathology, so I'm not going to go into it because it's too much. But you have clinical pathology, anatomic pathology, molecular pathology can be used in any or all of the different branches. And there are two main branches, clinical and anatomic pathology. And the others that I've shown over here, molecular and cytogenetics, etc., can be used in any of these other branches. Cytogenetics, FISH, molecular pathology is a very important part of hematology. It's an important part of anatomic pathology. And of course, you can always opt for clinical research. You don't have to do research just clinical or just doing clinical research as a whole-time profession. Any of these, if you're doing it, you can collaborate on clinical research, and there are so many pathologists who have written path-breaking papers because they have contributed in the team that is looking at clinical research. Okay, so there's a lot about the scope. Now I'll just come very briefly to why did I choose to be a pathologist? Okay, I chose to be a pathologist. Believe you me, at one time I thought that I would be. Let me tell you, I'm not a very energetic person. When I say energetic, I'm downright lazy. I don't like to be working 24 hours a day. I like my leisure time. I have leisure things to do. I like reading and I like listening to music and other things. So I really wasn't thinking of anything very clinical, though if it were clinical, I might have done obstetrics and gynecology because I was fascinated by this subject that had a little of everything. Okay. Abhinav says, same here, ma'am. Very good. You know, it has medicine, it has surgery, and it has pediatrics, and it has something that is, like somebody said, absolutely normal, but fascinating, and that's obstetrics. So it was like a combination of all worlds. But then, as I told you, I could not get up late, go to bed late in the night and get up early in the morning and rush around delivering. It was just too hectic for me. So what did it boil down to? It boiled down to dermatology and pathology. But I will tell you that my mind was made up, more or less made up for me, because I was inspired. I was inspired by my father, who was a surgeon, the gentleman on the left-hand side, who used to tell us at home stories about somebody whom he admired. And whom did he admire? He admired this gentleman on the right-hand side. If you don't know, you should know. He's Dr. M.V. Sirsat. He was a histopathologist, a surgical pathologist at Tata Memorial Hospital. Okay? My father was a surgeon at Tata Memorial Hospital. And my father actually passed away when I was doing my second MBBS. And my exams were in another couple of months. And he did ask me what it is that I would like to do. And I discussed it with him. And he said, listen, if your choice is between dermatology and pathology, obstetrics, you say you don't want to do because you're finding it too hectic. Take pathology, because pathology has a clinical component to it, not that dermatology doesn't, but it is something that helps so many other branches. Yeah, it is like he kind of said, what I have paraphrased, that it is the soul of medicine. And he had the greatest of respect for Dr. Sirsat. And I thought, well, if there is Dr. Sirsat is a pathologist, and my father respects a pathologist, and I had a deep love, affection, that is okay because he was my father, and a deep respect for him as an individual and as a surgeon, then I think I should do what Dr. Sirsat is doing, and that's how I decided to do pathology, although there were many people, including pathologists, who tried to dissuade me from doing pathology because, they felt that the clinical branches were perhaps more suited to me. And I realized soon enough that pathology was no less a clinical branch than all the others who had a misconception as to what pathology was. Okay, so the answer to the question as to why I became a pathologist, and that too a tissue pathologist, first and foremost is here. And I'm telling you, every day I feel privileged to see and to understand what others can only imagine. All right? Because I am looking under the microscope and I can get insights into the lives of the cells and their environment. And it is not only about disease. You see normal cells, you see how they are organized, you see actually how they talk to one another, and they do. And you can hear what, when I say hear, you can actually discern what it is that these cells are talking to one another. And you might think that in my old age, I've gone off my rocker. No, I have not. Okay. There is a language that cells speak to one another, and that same language is what they are speaking to you. If you don't know their sign language, then that's too bad. You have to learn the language, and once you learn the language, a whole new world opens out to you. Yeah, so they are talking to you. They are actually communicating with you. And I liken it to sign language. When you have a deaf and dumb person who's signing you, yeah, if you don't understand that sign language, then you're missing out on what that person is actually trying to communicate. So the first thing, if you're doing tissue pathology, whether it is cytopathology or it is histopathology, hematology for that matter, and I'm just telling you about tissue pathology, but whether it's molecular, fish, or any other thing, yes, you are somebody, just be careful about pressing that annotation button, okay? So I really feel privileged to be able to see that, how they relate to one another, they talk to each other, they function in concert with one another. And here is where the issue of normality comes in. Because I know how they deal with one another in a normal way, then I know when they are sick and I know when they are healing, okay? I also know, I can tell how and why they die. And once again, goes back to what I learned from Dr. Vijay Daftari. There I can see the evolution of normality and abnormality. And here I'm showing you something. Here there was a revision surgery. That means the patient already had surgery. This is an endo-submucosal dissection. So there was a polyp in the stomach, and they can now through the endoscope just take out the polyp. And in this case, they did it through a mucosal and submucosal dissection. Okay, and that one had a carcinoma at the resection margin. So they went in to revise that resection. And I will show this to you in little higher power. And now you will be able to see it. See this beautiful thing. There had been a polyp there. That polyp was removed. Okay. Now, if you have removed this polyp and you have done it with surgery, you expect something. And what do you expect? Okay, you expect healing and regeneration. So you see this at 1 second. Let me get something where you will be able to see my. Why can't I get a? Can you see my? Yes, pointer. Yeah. Okay. So now you can see this that you're seeing here. These two hyperplastic foveola. This is normal stomach mucosa, which is seen here to the right. Okay, it's a little distorted, but it is normal. Now, this is not normal. This is foveolar hyperplasia. And what is foveolar hyperplasia? You've got that crater which they have made when they did the first resection. And there is regenerative changes in the foveoli of the gastric mucosa that is taking place. Look at this. It's expressing so much mucin, right? It's trying to get back into normal. And here, there was obviously the mucosa had been removed, and this mucosa now has to regenerate. And you can see this regenerating epithelium here. I've pointed it out. There is granulation tissue here in the floor of this little ulcer that is present in the gastric mucosa, and you see the fibrosis that is taking place at the base. The youngsters over here, the students in your second year and third year, or one of you maybe even first year, if somebody points this out to you, okay, and you notice this, it is like a revelation, when you see this, and that helps you to notice things that other people don't notice. If you're just looking at this and matching pictures, I'm sorry, the romance of pathology for you, the soul is dead. You have to look at this process as a dynamic process. Okay, what is happening over here? A consequence in this case of what was done to this before. And once I realized what Dr. Daftari might have been, as they say, taking the mickey out of me, because he liked to take the mickey out of pathologists. But the realization that came to me from trying to answer that question, in a way, I was mad as hell. But that realization, when it hit, everything that I see or do now is done in this light. I am looking at it in a dynamic fashion. Whether I'm looking at an endometrium, and I'm looking at an endometrium, I'm not saying, oh, this is late proliferative phase, and this is this phase or that phase, and I'm matching pictures in the book. No, I am looking at this endometrium in the context of what hormones have acted on it, and how has this endometrium reacted to those hormones. And once you have done it, there is no going back. You will understand what is happening with such a deep way that your curiosity and your passion will drive the rest of your life. Now I can hear people saying, oh, well, how can you do it in clinical biochemistry? And oh, how can you do it in clinical? Oh, you can do it in anything that you do. You are doing follow-up work on a patient who has got diabetes, and you can see the ups and downs of how that diabetes is either improving or not improving. You can make suggestions as to what is likely to be happening in the kidney or in the eye or anywhere else by just following what's going on in these. So, it's about getting a passion and a feeling for what's going on. Okay. So there's another thing. I mean, if you're a pathologist, you can call the shots. Yeah. Nobody can treat without a pathology report, and you can be the power behind the thorn. For me, as a tissue pathologist, my report more or less tells clinicians, cut this out. This is not going to, no surgery is required here because the margins are going to be compromised. You need post-operative radiation. This will respond to anti-hormones, that will respond to targeted therapy. All this I can do. This is not malignant, no matter what it looks like. On the radiologist might think it's malignant, but this is not. Okay. And of course, frozen sections, which is the epitome, the absolute top of calling the shots. It's called the hot seat of its intraoperative consultation. Okay. Now, sometimes we look at material that is sent to us, and yeah, okay, somebody will say that this is just a hemangioma. No, it's not just a hemangioma. I have seen grungy calcification here, so I say, hey, get the phosphate levels done. And this patient actually did have a phosphaturic mesenchymal tumor. Now, all of this because I am looking at these things in a very directed way. These were called cancers. Okay, you see this destructive disease over here, which has gone across joints. Here is this huge bump, and you can see that it has destroyed the scapular and the lateral end of the clavicle. This one is gout. And that one is rhinosporidiosis of bone. Now, when something like that happens, You feel so good that you were able to save somebody's limb, somebody's major operation. Okay, you can do as me as a tissue pathologist. I do microbiology. I also do mycology, parasitology, virology, because I can see the changes in the tissues. Now here I see tissues, and I don't know if one of you wants to see. What do you see over here? These are histiocytes, and they have a pale appearance. They are known as foamy histiocytes. So when you see foamy histiocytes in a lymph node, what should you worry about? And we found it. This, you see the globi on a Fight Faraco stain. It is a modification of a Ziehl-Neelsen stain, and this is Hansen's disease or leprosy in a lymph node. Okay, and here is a biopsy from the penis. It was a warty growth in a 69-year-old male. And yeah, it was a sarcoma. But why did he have a sarcoma on the penis? Well, he happened to have a Kaposi sarcoma. And this is showing you, as you see over there, HHV8. This is the latent nuclear antigen of Kaposi sarcoma. So that is something interesting. And this gentleman obviously had to be treated for that. And somebody in the chat box, I don't know if these students will be able to, this was an 80-year-old frail woman with a sacrococcygeal bed sore, which was biopsied. You see these big things over here. Anybody wants in the chat box to tell me what it is? It's very diagnostic. And when you see something like this, it's not just a decubitus ulcer. You know exactly what it is. I don't see anybody replying in the chat box. It is anal amoebiasis. This poor lady, you know, was just had amoebiasis and passing mucus. It was all collecting over there because obviously she was not being looked after well, and there was anal amoebiasis. And I also practice what is called surgical pathology. Okay, and this is not just diagnostic. I told you, we are not in the business now of doing just diagnostic pathology. We help clinicians make management decisions. Okay, and this is the famous Juan Rosay, who wrote this book called Guiding the Surgeon's Hand. Indeed, surgical pathologists do guide the surgeon's hand. And how do we do it? Well, we provide information that helps them what to do next. Okay, diagnosis, of course, tells you this is squamous carcinoma, therefore at a particular site it will respond to radiation. In some site you may want to take it out, but we stage the disease. We say how far it has gone, how deep it has gone, are the nodes involved, not involved, and therefore that guides a decision on whether any additional therapy has to be given. That is what is adjuvant therapy. Should this patient receive additional chemotherapy? Should they receive additional radiation therapy? Or if you have given chemotherapy or radiation therapy and then you do surgery, then was that chemotherapy complete, in the sense, had it produced complete regression of the disease? Did the radiation therapy do that? If it did not, does that chemotherapy now need to be changed? Also, we predict what kind of response to therapy, to targeted therapy, there's going to be. And of course, quite often we provide information on prognosis. In other words, what we're doing is that we are providing information, all, whether it is diagnostic information or any of these, that is relevant to patient management. And it is not just tissue pathologists that do it. Hematologists do it, molecular pathologists do it, clinical biochemists do it. Every time that they give you a report that says that there is a level to something, you get an idea of how much, like if you have a myeloma, for instance, everybody knows that there's a myeloma, but that myeloma is followed up by clinical biochemistry. How much of myeloma protein is being produced? What kind of myeloma protein? Is this kappa light chain restricted myeloma? Is it a lambda light chain restricted myeloma? Has that myeloma stopped producing protein and yet there is a myeloma? Has it gone crazy? Is there P53 that has come into the system? All this can be done by clinical biochemists. So don't poo-poo some areas. Oh, anatomic pathology is the greatest in the world. No, all, and I'm saying surgeons here because I'm doing surgical pathology, but all of medicine, all is dependent on pathologists. Okay, whatever kind of pathology you may be practicing, please remember that you are part of a team. You are a clinician first and last. Okay, so there it is. Surgical pathology, if somebody needs to define it, is tissue diagnosis that is directly involved in clinical decision making. It's not something that is just histopathology, some cytopathology. No, it provides more than just a diagnosis. Okay, here is an example. This is an osteogenic sarcoma. This kid was given chemotherapy, which is the standard of care now, before doing the surgery. And once that bone comes out, then we need, as pathologists, we draw a little grid, which you can see over here, and we tell them the percentage necrosis in an osteogenic sarcoma. And this is a huge thing, okay? Somebody said if only a lot of surgeons would understand this. Oh, they do, okay? Only thing is that they sometimes have to be made to realize it. Okay, you know, we don't only do this, we also have a quality assurance function. Our surgical pathology provides quality assessment of clinical competence. Every time I see this, and these are known as the mesorectal buttocks, if a surgeon is doing a low anterior resection, it should come out like this. If it comes out like this, okay, or this, it means that the surgeon has violated a plane. And if sometimes he can't help it, but if he's regularly violating a plane, that means he's choosing the wrong kind of cases or he's not a very good surgeon. Okay, and this is something that we include in our reports. Not saying that you're a bad surgeon, but we give the the quality of these mesorectal buttocks. So margins of resection, when we say that the margins are compromised, or they have to, in some cases, dissect a minimum number of nodes. If they have not done it, then the minimum number of nodes tells them that their surgery may not have been of the quality that is required. So it's not just diagnosis and this and that. There is also a quality assurance function. We do what is known as predictive pathology, often called theranostics, means therapy-related diagnostics, okay? And this relies on the molecular understanding of the disease and then how we tailor the treatment based on this understanding. And if you have to put it in a nutshell, it provides the right treatment for the right patient at the right time, and is being done day in and day out. Every time I say that this breast cancer has an estrogen receptor or a progesterone receptor or HER2, or it's not being expressed, okay, then accordingly, the patients get or do not get anti-estrogen therapy or HER2 related therapy. Every time I write somewhere that a CD20 is expressed on a lymphoma, it gives the treating physician in defined situations the option to use rituximab, which is an anti-CD20 antibody. And of course, you all know about gastrointestinal stromal tumor. And once we say that a CD117, or it's known as c-KIT, is expressed, it helps you to diagnose the tumor, and it tells the clinician that this will respond to a drug which is called Gleevec. Okay, so what do I call surgical pathology? Walking with clinicians. Now, you see these three pictures over here? When you are walking away from someone, your perspective cannot be the same. Now, this was in the days of Manmohan Singh and Sonia. When Manmohan Singh is walking away from Sonia or vice versa, her perspective is in this direction, his is in that direction. So obviously the perspectives are not going to be the same. Their perspectives are not the same even if you are walking towards somebody, because you know what is a perspective? The direction in which you are looking. Now here Manmohan is walking. Yeah, they're probably going to even shake hands. But his perspective, once again, is in this direction and hers is in that direction. Okay? But if you're walking with somebody, your perspective, his and her, or yours and the other's perspective are the same. And you can actually see her hand saying, let's do this together. So I say that surgical pathology, and you could replace that with hematology, clinical pathology, any pathology, is about walking with clinicians. Okay? And this was said very well. Of course, it was said about surgical pathology, but I think it is about any pathology. And what does it say? A surgical pathology report is as valuable as the combined intelligence of the pathologist and the surgeon makes it. Okay? And what is this intelligence? It's it's an analytical function in the context of a clinical, of your clinical understanding of this disease. So please, pathologists are doing a fantastic job. Okay, they are clinicians. I can go on and on. Okay, but yes, of course, I just put it in because I do hematology, hematopathology. This is a bone marrow. Okay. Of course, nothing remains the same. A whole of pathology is changing. Yeah. In the beginning, we used to do gross pathology, and now we are doing spectral pathology. Okay. Molecular medicine has come into the picture. Everybody wants to do molecular medicine, but remember that molecular medicine touches all aspects of pathology. So you can do molecular medicine in hematology, you can do molecular pathology in anatomic pathology, in every branch. In microbiology, you know, the whole COVID epidemic. What were we doing? We were doing molecular medicine. Okay? And why? And I'm just talking about surgical pathology. You know that we say DNA makes RNA makes protein. And because as a pathologist, when, you know, everybody says, oh, immunohistochemistry, I don't know whether you understand that immunohistochemistry is actually doing something which is called imaging protein. So we image proteins because proteins are immunogenic, and that you can make antibodies to proteins. And so that's the immunohistochemistry. It's carbohydrates and fats are not antigenic. And if they are antigenic, it's because they are combined with proteins. So glycoproteins are antigenic. Yeah, and similarly, fatty acids combined with proteins become antigenic because it's the protein part of that molecule that is actually antigenic. All right. And so we can do molecular imaging. I'm doing molecular imaging every day in my lab, and anybody who does immunohistochemistry is doing it. You can show the presence of a protein, or you can show the loss of a protein. Okay, loss of expression. So we can do wonderful things. We can do it for lung tumor markers. You can do it by fish. You can do it by immunohistochemistry. Now there are labs that do molecular profiling, but very few because it's very expensive and it doesn't always give you the answer that is needed. Okay, but things are getting even better. Everybody knows about flow that is being done in hematology and in microbiology and in several other. But can histopathologists do flow? Yes, it's coming soon, and that is what is called quantum dot imaging, flow on a slide. So that is also there. Now we can use spectra to look at and use these. These are not true colors. Okay, just like in flow, you don't have true colors. They say it's only 16 color flow and this and that. But you can, on your plots, the colors are just made up. Okay, you can't see the fluorescence on your plots. So here these are made up colors, but they reflect the spectrum that has been hit. Sorry, the slide has been hit with this infrared spectrum. Okay, and that's why very soon you can do protein mapping without antibodies because you use mass spectroscopy, exactly the same mass spectroscopy that is used in big labs to do protein mapping, but then you get it as dots on a gel. Here you will be able to get it on a slide, only you won't be able to see it. It'll have to be done by by the bioinformatics people. Okay. Of course, we are all doing this now, virtual microscopy and AI. AI is going to become a big part of all of the different branches because number one, it takes away the tedium of pathologists looking, counting, etc. Yeah, so like measurements. And very soon, maybe expert systems where it is trained with many different by expert pathologists, obviously, and it trains the system to recognize something which would be of diagnostic value. All right. Of course, now people are doing liquid biopsies to find out whether a tumor has come back or not come back and what kind of molecular pattern that it has. This is not the time to go into all of this, but there are new pathologies changing all of the time. This is very much in the realm of a molecular pathologist. But let's not forget that there are simple things that we do, CBCs, everyday things like doing sugars and creatinines, and they're very simple things that have stood the test of time. And here is what one Rosai said: there is no technique in all of medicine that provides so much information so quickly and for such little cost as the H&E technique, which is true. Yeah, when you think of how soon you can get information. And in, as I say, it is sundar, it is sasta, and it is tikau. And here I'm showing you, this is a renal cell carcinoma. Okay, it's a clear cell renal cell carcinoma. And what information do you get from this H&E report? That it has a potential for lymph node, lung, bone metastases, rare regression of metastases with removal of the primary, all this information, yeah, that there's VHL function is abnormal, the VHL gene is on 3P, and this will respond to anti-angiogenic agents, mTOR inhibitors, and TKIs, and all for the price of a histopathology report. Okay, so I come to the end. Why do I remain a surgical pathologist? And you could replace that surgical with why do I remain a pathologist? Okay? Because I enjoy walking and talking with my clinical colleagues, because together we make patients better. And I'm saying this again and again. I am a clinician first and last. I remain passionately curious, and I am literally begging all of you, start becoming curious. The passion will come about what is going on in the human body. And surgical pathology satisfies this curiosity every day. Every day. Now you can remove the surgical and pathology will satisfy this curiosity every day. I can tell you, I have been privileged to meet so many young minds. And today I have met all of you. I have met you, Mansi and Jyoti and Abhinash and Dharani and Ajay and Aarti, yeah, and so many others. I have been privileged to meet so many young minds and open this fascinating world to them. Okay? I have been inspired by giants and I strive to emulate them. Okay, that's Rosai. I did meet him. Of course, Sirsat, and my father always remains, close to my heart. This is this kind of inspiration I wish that each one of you could have in your lives. Okay, so what's the answer to why pathology? Come on, any one of you? What is the answer to why pathology? Yeah, what's the answer to why pathology? It's why not? Absolutely. Why not? I hope I have been able to tell you that there is nothing that you as a pathologist cannot aspire to, cannot do, cannot inspire other people by being a pathologist. So you're already doing pathology. I don't have to motivate you to become a pathologist because you're already pathologist. But I can certainly tell you that you should get up every day and say, all right, I am going to be the best damned pathologist that I could ever be. And if you say that to yourself and you approach this like you would approach a clinical problem with curiosity and passion, then that's all. What else do you want? What's the point in going through your professional life saying, oh, I wish I'd been a pediatrician. Now I'm sad that I'm not a pediatrician. I'm sad I couldn't do. No, you are a pathologist and you are, I would say, Superman or Superwoman. What is it that they can do that you cannot? You can do what? Everything. Okay, you may not be able to open and close an abdomen. Okay, but is that such a big thing? I don't think so. Right? Okay. So I think that's the end of my thing. Let me, yeah. Okay. So that's it, folks. Is there anything that you want to ask? Oh, there is somebody, Jayati says, my guide used to tell me that we are the consultants to the consultants. Yes, very good, Jayati. We are proud and privileged to be pathologists, of course. All right, that's right. So, are you going to be, we are all pathologists. Are you going to be better pathologists now? Yes?
Yes.
Aarti?
Yes, ma'am.
Okay, Aarti wanted to be a pathologist. Ajay, are
Yes,
you
ma'am.
inspired?
Yes, ma'am.
Yes, ma'am.
Now, what else are you going to say? Anyway, Shubham, are you a pathologist? Dr. Shubham. Oh, he can't say anything because he's muted. Okay. All of you are there. I can see your pictures. Okay. So thank you very much. I feel passionately about this. So I took a little longer than I should have, but that's it. And does anybody want to say anything? Any of you students? Because you can say, the others are talking in the
Thank you
chat.
so much, ma'am. Yeah,
Thank
can
you,
I?
madam.
Yeah, that's Dr. Ramaswamy. He said something. Wait one minute.
Ma'am,
Yes. Can you read out what Ramaswamy said? Yeah, he said, when our medical director told in a clinical meeting that Sorry, I've lost Ramaswamy again.
There
Can
are,
I say something?
Yes, sure, please.
yes.
Yeah, thank you so much for the wonderful session, for raising the curtain for why we should be a pathologist. And I think we'll take good messages at home for this. And thank you for all my peers, for all the moderators, for a wonderful session. And
very good.
OTP PG4 starting, and it should be a big success, and we should take a lot more information, and we should strive very hard to be a good pathologist.
Yes,
But
I know.
ultimately, we are working for patients.
Yeah.
And
But please,
that's all.
whatever all said and done, okay, never feel inferior to a clinical colleague. There is no clinical colleague who can stand, unless you can respect your clinical colleagues and you can respect expertise, you can expect respect, and I do, professionalism. Yeah. But I do not think that I am any less worthy of their respect or their admiration. Okay, because I think that they're dependent on me. So, okay, good. Thank you very much, Mansi. Thank you,
Thank you,
thank you,
ma'am.
Sakshi. Thank you for sharing your
Thank you,
insights,
ma'am.
and thank you, Bonita.